Good evening, everyone. This is Leena Allabboudy. I'm a postgraduate from Al Faisal University and a dermatology resident to be, inshallah. So today I'm going to be talking about common skin infections. So in general, I'm going to be giving you a general idea about each infection, more like a pattern recognition approach. So we're going to be talking about some bacterial, viral, and fungal infections. So in order to understand the common skin infections, we have to know the anatomy of the skin in order to know which part the organism or its toxin will target. And therefore, you're going to have a better understanding of the clinical presentation of each infection. So we're going to be starting with bacterial skin infections. So as I mentioned before, you have to know that each organism will have a specific area in the skin that it will target. For example, as you can see here, impetigo will be a more superficial infection affecting the epidermis only, compared to erysipelas and cellulitis, which affect deeper areas in the skin. And we're going to go into details in a minute. So first off, we're starting with bacterial folliculitis, which is a localized inflammation of the hair follicle or sebaceous glands. It first presents with pustules in follicular distribution, which is areas associated with hairs. It happens because of occlusion or hair manipulation, commonly like shaving, plucking, or waxing hair. The most common organism causing it is usually Staph aureus. However, it can occur because of contaminated water, and in this case, Pseudomonas aeruginosa will be the causative organism, and hence the name hot tub folliculitis. The treatment is pretty simple. If the folliculitis was superficial, you only use antibacterial washes like chlorhexidine and antibacterial ointments like mupirocin. Next is furuncles, also known as boils. Now they're a kind of folliculitis, but with a more deep and into the dermis with abscess formation. They start off as tender nodules with necrotic plug, as you can see in the top picture. And then when the abscess formation starts, it presents as a central pustule. And then eventually it ruptures and results in discharge of necrotic material and pus. Now, again, the causative organism most commonly is Staph aureus. But since it has an abscess formation, it can also be caused by methicillin resistance Staph aureus. The treatment of furuncles usually depends on if it's simple with no fluctuance, meaning that the abscess did not form yet, you can only use warm compresses. Whereas if there's fluctuance or abscess formation, you have to do incision and drainage and clear out the infection. And if it's complicated, meaning it's located near the midface, or if it's recurrent, or even if it's very large, you can use oral antibiotics. Next is carbuncles, which is basically coalescing of a group of furuncles, and it presents with multiple draining sinuses, as you can see in this picture. Usually in the nape of the neck or back of the thighs. It can also present with systemic symptoms such as fever, chills, and fatigue. The causative organism, again, is Staph aureus. So you can see that folliculitis, furuncles, and carbuncles represent kind of a continuum of severity of a Staph aureus infection. The treatment, again, is incision and drainage because it's a deeper infection, and systemic antibiotics. Next is impetigo, which is also known as spool sores. It's a highly contagious infection of the upper layers of the epidermis. It's usually spreads by direct contact with the lesion. That's why it's highly contagious. And it's the most common in children. Now, the types, it can present as the bullous type and the non-bullous type, but usually has a characteristic thick honey yellow crust appearance, which is mostly seen on the face. Now, they can both types can be caused by Staph aureus. However, the non-bullous type can also be caused by group A strep pyogenes bacteria. The treatment also focuses on topical antibiotics, and you can also use oral antibiotics if it's extensive. Next is cellulitis. It's an acute bacterial infection, usually of the deep dermis and subcutaneous tissue. Now, it can occur anywhere on the body, but it often occur on the legs, face, or arms. And usually appears in areas of broken skin due to trauma or any other infection, and presents with a dull pale red skin lesion with indistinct margins, meaning that you can't really trace the edges of the lesion. It can also be accompanied with vesicles, bulla, and necrosis. Most commonly caused by group A strep pyogenes, and less commonly by Staph aureus. The treatment is usually oral antibiotics, but it has to have a good gram-positive coverage in order to stop the spread of the infection. Then we have erysipelas, which is a type of superficial cellulitis associated with significant dermal lymphatic involvement. And to differentiate it from cellulitis, it usually has a well-defined sharp raised borders, so you can actually trace the lesion on the face and legs. It's usually also accompanied with constitutional symptoms like high-grade fever, chills, and malaise. It can also, it's usually caused again by group A strep pyogenes, just like cellulitis. The treatment is with penicillin. It has a good coverage. If there is a penicillin allergy, you can substitute it with macrolides. Moving on to viral skin infections, we're going to start with varicella infection. So varicella has a kind of a primary course and a secondary course. It's a highly contagious infection. It has an airborne droplet and direct contact transmission, hence the highly contagious part. As the primary infection, it causes, it's usually named chickenpox. And as this infection subsides, the virus becomes dormant in the spinal dorsal root ganglion. It can be up to years. And once a stimuli is present, like an infection or severe illness, it can be reactivated into herpes zoster, also known as shingles, which we're going to be talking about in a minute. For chickenpox, usually the age of onset is less than 10 years. It presents as grouped painful erythematous macules and papules in a single sensory dermatome, as we said, because it's in the dorsal root ganglion, so it follows this specific dermatome. And it has a characteristic dewdrop on rose petal appearance, as you can see here in the picture. Then it enlarges, becoming vesicles, and eventually ruptures, giving us the dry crusts. And this is usually the non-infectious form of chickenpox. The treatment is usually in healthy children. It's usually a symptomatic treatment. You just give them antihistamines or topical antibiotics. However, for adults and immunocompromised, you use systemic antivirals, and it's best used within 48 to 72 hours within the appearance of the rash. Fortunately, we have a preventive vaccine, which is called Varivax for chickenpox. Next is herpes zoster or shingles. As we said, it's a secondary infection of varicella zoster virus. It's characterized by unilateral pain and vesicular or bullous eruptions limited to the dermatome that it was dormant in. And usually, as you can see in the top left picture, it's affecting the ophthalmic division of the trigeminal nerve. So as you can see, it does not even cross the midline, just follows the specific dermatome. And in the lower pictures, it's affecting the maxillary division of the trigeminal nerve. Now, the treatment is the same. It's systemic antivirals, again, used within 72 hours of the eruption in the immunocompetent. Now, it usually affects people above 50 years of age, and it's less likely to come in children. And again, fortunately, you have Shingrix vaccine for prevention. Now, herpes simplex is another neurotropic virus which hides in the dorsal root ganglion until, again, it's reactivated. So just like varicella zoster, it starts with a primary infection. And then the latent phase, it becomes dormant in the trigeminal ganglion specifically. And then once it's reactivated, it then goes into the lips and perioral skin. So we have two types of herpes simplex. The type 1, which is mainly orolabial, but not specifically just orolabial. It can also be genital. And the HSV type 2, again, mainly genital. Now we have two courses, the primary and the secondary infections. The primary infection of the HSV type 1 has a characteristic abrupt onset of gingivostomatitis, which is basically an erythematous or friable gingiva. And then you have the appearance of painful vesicles that cluster on the oral mucosa, the tongue and lips, which then becomes vesicles and they rupture, producing small ulcers. The secondary infections, you only have the grouped vesicles when the erythematous space, such as the picture, and eventually resulting in painful ulcers. And as you can see, it involves the vermilion border of the lips. The HSV type 2 starts with constitutional symptoms like fever and fatigue. And then they develop painful grouped vesicles in the genital area, which eventually result in tender, very painful ulcers and painful lymphadenopathy. However, in the secondary infection, there is a characteristic prodrome of paresthesia up to 24 hours before the grouped vesicles and the ulcers appear. Next is the human papillomavirus, or HPV. It's a non-enveloped double-stranded DNA virus with more than 100 different types, usually affects the epithelium and the mucosa. The types can be divided into benign or low risk, for example, like HPV 6 and 11, and the high risk, like HPV 16 and 18, and this is more associated with carcinomas and high-risk infections. It's usually spread through direct skin contact, and one of the most common infections caused by HPV are warts, which are benign hyperplasia of squamous epithelium of the skin and mucous membranes, along with hyperkeratosis. Now, for warts, we have two different manifestations. It can be non-genital, which is also called common warts. It spreads through skin-to-skin contact, happens through a minor breach in stratum corneum, which is the outermost layer of the skin. And it can be anywhere on the body, but most commonly the hands and fingers, as you can see in this picture, and as well as the feet. In case of the feet, it can also be called plantar warts. And the types of causing non-genital warts are HPV type 1, 2, and 4. For the orogenital warts, it's usually sexually transmitted, with types HPV 6 and 11 most commonly causing it. It can also be caused by HPV 16, 18, 31, 33, and 45. However, these are more associated with dysplasia, like cervical dysplasia in women, squamous cell carcinoma, invasive squamous cell carcinoma in both genders. Lastly are fungal infections. So there are two groups I'm going to be talking about. The first group is dermatophytes. They are fungi that require keratin for growth. We have three genera of the fungi which are capable of invading keratinized tissue, which is the microsporum, the trichophyton, and the epidermophyton. Now, dermatophytes are also called ringworm or Teena, which is the Latin word for ringworm, and they're usually named according to the anatomic location that they occur in. So, for example, if they're affecting the epidermis, it will include Teena pedis, manuum, crurus, corporis, and fasciae. The hair is Teena capitus, barbae, and nails, Teena anguum. Now, starting with Teena pedis, which is also known as athlete's foot, infecting the feet, they present with erythema and scaling maceration, as you can see. Can be unilateral or bilateral. And usually these happen because of a hot, humid weather or occlusive footwear or sometimes sharing footwear. Tinea manum affecting the hands usually presents with diffuse hyperkeratosis, and you can see the accentuation in the creases of the hand. And in 50% of the cases, it's unilateral. And both Teena pedis and Teena manuum can be treated with topical antifungal. You only use oral antifungals if it's extensive. As for Teena anguum, it affects the nails, presenting as discolored white, gray, or yellow brittle nails. Now, the treatment here is oral antifungals because the topical antifungal cannot really get to the nail, as you can see. For Teena faciae, it affects glabrous facial skin, which is the facial skin that has no hair in it. That's why it's most commonly seen in children. Presents as erythematous serpiginous plaques with scaling on the face. Serpiginous plaques meaning they have like a kind of wavy borders. Then Teena corporis, usually affecting the trunk, abdomen, and limbs, presenting as erythematous, sharply marginated, scaly plaque with central clearing, as you can see in this picture. And both Teena faciae and corporis can be treated with topical antifungals. Again, if extensive or it involves any hair follicles, you go for oral antifungals like terbinafine or itraconazole. The Teena crurus, infecting the upper thighs and crural folds, rarely involving the scrotum, presents as erythematous patch with raised serpiginous scaly borders and central clearing, kind of similar to the Teena corporis lesions, and you can treat them with topical antifungals. Gina Capitus, usually infecting the scalp, the eyebrows, and eyelashes, again, most commonly seen in children. Now, it depends on the degree of infection. For example, the endothrax, as you can see, the fungal spores usually are within the hair shaft. The cuticle is usually intact, and the hair usually breaks at the surface. So you can see a characteristic black dot appearance. It also has some other variants, like the favus, which is a yellow cup-shaped crusting appearance, like this one. And the chirion, which has a more inflammatory kind of reddish plaques. For the ectothrix, the fungal spores usually coat the outside of the hair, and the cuticle is destroyed, and therefore it kind of has a dull grayish discolored appearance. The Teena barbae, affecting the beard and mustache area, presents as a painful inflammatory nodular swelling, as you can see. The treatment of both is usually oral antifungals. Now, the second group is the Candidiasis infection, most commonly caused by Candida albicans. Now, it has a wide variety of presentations, but one of the most common is the thrush or pseudomembranous candidiasis, most commonly affecting the mucosal surfaces, such as the tongue, presenting with a gray-white plaque with reddish maceration. So the tongue kind of appears as a bright red color. And Candida intertrigo, which is from the name, affects the intertriginous areas, which are basically body folds. So including the axilla, the inframammary area, inguinal region, gluteal folds, and it presents as a pink to bright red moist patches. Most commonly has a characteristic satellite papule or pustule appearance. And again, it can be treated with antifungals like amphotericin B specifically, ketoconazole, fluconazole, and itraconazole. Thank you very much. If you have any questions, please don't hesitate.
يعطيك ألف عافية دكتورة لينا. Attendees, as you might have guessed, you may now send your questions يا إما بالQ&A or you can use the chat and I'll be happy to read them to the doctor. أهلا دكتورة. There's a question asking, what is the difference between Teena corporis and Teena Facial?
Okay, just a second. Okay, so as you can see, the first difference is the presentation. So Teena Facial tends to present more on facial skin, and it has an erythematous scaling kind of rash compared to Teena corporis, which does not affect the face. It's usually on the trunk, abdomen, and limb. And it has a sharply marginated kind of plaque as opposed to the wavy margin of faciae, and with a central clearing characteristic appearance.
Okay, شكرا يعطيكي ألف عافية دكتورة لينا for taking your time to explain to us this lecture so clearly.